TFE3 rearranged renal cell carcinoma. Clinical features are the clinical presentation of TFE3 rearranged RCC as a renal mass is not specific, although occasional cases are heavily calcified on imaging, which can mimic renal lithiasis. Toffee, TFE, you can remember as a toffee. Toffee will be center, what it will be there, stone like toffee will be there, no? So it mimics the renal lithiasis because of the heavily calcification on the imaging. Epidemiology approximate 40% of the pediatric RCCs and 1.6 to 4% of adult RCCs are a TFE3 rearranged RCC. So basically this is most majoritarily a pediatric RCC. Toffee is a pediatric, right? Toffee, who will eat toffee? Pediatric. Center what will be there? Calcification. What is it? Calcification, it is a renal lithiasis kind of. Etiology, cause is a prior exposure to the cytotoxic chemotherapy is a risk factor for a MIT family association RCC. Prior exposure to the cytotoxic chemotherapy is a risk factor for MIT family translocation RCC. Pathogenesis, overexpressed TFE3, TOFE3 gene, TOFE3 fusion proteins, overexpressed TOFE3 fusion proteins, TOFE3 fusion proteins act as aberrant transcription factors that activate expression of multiple downstream targets, including those normally activated by the related MIT family transcription factor MITF, such as melanocytic markers or a cathepsin K. Macroscopic appearance is a TOFE3 rearranged RCC do not have a distinct gross appearance. They don't have any distinct gross appearance. Okay. Histopathologically, the usual histological pattern of a TOFE3 rearranged RCC is that a papillary neoplasm composed of epithelioid clear cells with abundant samoma bodies. Okay, how do you remember? This is not an exact way to remember. Okay, how I remember is that a papillary neoplasm composed of epithelioid clear cells with lots of samoma bodies. This is what is called as a toffee. You know, toffee is sitting on the cushion like toffee. So this toffee, okay, toffee. So composed of epithelioid clear cells with abundant samoma bodies, TOFE3 rearranged RCC can also mimic other renal neoplasms, including clear cell RCC, papillary RCC, clear cell papillary RCC. You know, it is called as a tumor, perhaps multilocular cystic renal cell neoplasm of a low malignant potential, which comes under clear cell variant, oncocytoma and epithelioid angiomyolipoma. Occasional TOFE3 rearranged RCC contain melanin pigment. Toffee is a black color toffee, right? Melanin pigment, creating an overlap of a TOFE3 rearranged pigmented perivascular epithelioid cell tumors, which are picomas. TOFE3 rearranged RCC contain melanin pigment, creating an overlap with the TOFE3 rearranged pigmented perivascular epithelioid cell tumors, that is picoma. Unlike typical picomas, perivascular means perivascular, this is vessel, perivascular around the vessel there is a tumor, epithelioid tumor. It is also an epithelioid tumor. Perivascularly there is an epithelioid tumor, it is called as a picoma, right? Okay. Unlike typical picomas, TFE3 rearranged picomas typically affect young patients, as we have described. They almost always have an exclusively epithelioid clear cell morphology. They have minimal to no immune reactivity for muscle markers no reactivity, and they do not demonstrate inactivation of a task 1 task 2 gene, or a clinical association with a tuberous sclerosis is not there. In contrast to most RCCs, TOFI3 rearranged RCC under express epithelial markers such as the cytokeratins and EMA, but they do consistently express PAX8. Occasional TOFI3 rearranged RCC express melanocytic markers like melan A and HMB45, and approximately 60% label of for cathepsin K. Strong nuclear TOFI3 immunoreactivity using an antibody against an C-terminal portion of a TOFI3 is highly sensitive and specific for TFE3 rearranged RCC, but TFE3 break apart fish assays have generally proved to be more useful because they suffer less from fixation tissue issues. The key exception are TOFI3 rearranged RCC resulting from paracentric inversions involving XP11. These are often challenging to detect by conventional TOFI3 break apart fish, giving a false negative result. Such fusions include RBM10 TOFI3, GRIPAP TOFI3, RBMX TOFI3, and nonotophy3. The diagnosis can be suspected when a neoplasm demonstrates other typical features of TOFI3 rearrangement RCC such as cathepsin K immunoreactivity and characteristic morphology. So basically, if you have to take something from all of this, whatever I have read, TOFI3 is cathepsin positive, cathepsin K positive. So toffee, right? Toffee is there, right? Black. Melanin also positive it is. This is solid, that's why renal lithiasis. And how do you remember? I am telling, okay? Toffee 3 rearranged cathepsin. No? Cathepsin. These are like C, right? These are like C. C. These are looking like C. So cathepsin. K immunoreactivity and characteristic morphology along with a strong diffuse nuclear toffee 3 labeling by immunohistochemistry. The diagnosis can then be confirmed by RNA sequencing RT-PCR fish using specialized phosphamide break apart probes. Diagnostic molecular pathology. Before going to that, first of all, let's see this histology TOFI3 rearranged RCC. Note the solid to papillary architecture and some bodies. Where are the samoma bodies? These might be samoma bodies. These are papillary arrangements. Okay, papillary arrangement, samoma bodies. Note the solid nested areas resembling clear cell renal cell carcinoma at the bottom and papillary architecture at the top. So this is kind of a renal cell, clear cell. It is kind of clear cell, but here you can see the papillaries. Okay, papillaries, so many papillaries are there. So it can show papillary also, it can show the clear cell kind also. This tumor with the ASP SCR1 TOFI3 fusion demonstrate voluminous cytoplasm and samoma bodies, and voluminous cytoplasm. Okay, here everywhere voluminous cytoplasm is there. TOFI3 diagnostic molecular pathology is TOFI3 rearranged RCC harbor fusion of a TOFI3 transcription factor gene on chromosome XP1123 with multiple reported genes including ASP, SCR1, ASPL, PRCC, NONO, SFPQ, RBM10, MED15, CLTC, DVL2, PIRP14, so many markers. The three most common fusion identified in TOFI3 rearranged RCC involve the PRCC, ASPSCR1, ASPSCR1, same gene fusion found in the alveolar soft part sarcoma, and SFPQ. So the three most common fusions identified in the TFE3 rearranged RCC. TFE में if you have to have an identify rearranged fusions, this is TOFI, right? There are fusions here. That fusion they are talking, one is PRCC, one is ASPSCR1, one more is SFPQ, SEPQ. The SFPQ fusion is also commonly found in the TFE3 rearranged picomas and melanotic TFE3 rearranged renal cancers. Overexpressed TFE3 fusion proteins act as an aberrant transcription factor that activate the expression of a multiple downstream targets, including those normally acted by the related MIT family transcription factor MITF. Essential and desirable diagnostic criteria are: essential is a strong nuclear labeling of a TFE3 by immunohistochemistry in a clean background, or a TFE3 rearranged identified by a break apart FISH and TFE3 gene fusion identified by RNA sequencing. What is desirable is RCC with a mixed histological pattern, including clear cell, papillary architecture, and some homobodies. Here you can see in this diagram TFE3 rearranged renal cell carcinoma with a strong nuclear labeling to the TFE3 protein by immunohistochemistry. Note the absence of the labeling in the native endothelial cells. Staging: TOFI3 rearranged RCC are staged using guideline for adult RCC. Guideline is a adult RCC, but it is kind of pediatric RCC. The prognosis is a survival patient with a XP11 translocation RCC is similar to that of the patients with a clear cell RCC and significantly worse than that of the patient with the papillary RCC. If you have to grade based on the prognosis, worst prognosis, clear cell is equals to this one, TOFI 3 survival, and then comes the papillary, which is having slightly better. In a multivariate analysis, only distant metastasis and older age at the diagnosis is independently predicted death. Pediatric patients have a lower burden of genomic events than adult patients, which may explain their better prognosis. In children it is better, in adults it is very bad. In children it is good.